I think this is record in-person attendance. So it's nice to see the state of emergency ending and hopefully the winter viral surges calming down and people wanting to see each other and feeling safe to do so. So thank you everybody for being here. At the end, if there's time, we'll just do introductions around the room so people know who's here and get to actually connect names to faces and Zoom avatars to actual human bodies. But we won't do that now because we want to make sure that we have enough time for your presentation and all the questions that might come in both from our Zoom attendees and our in-person attendees. So today we're really excited to have Laura Gottlieb here as our speaker. She is a physician who also has a master's in public health and is an associate professor in family and community medicine at UCSF, which is my academic home department too. And her research explores programs and policies related to increasing healthcare systems capacity to identify and intervene on social risk factors to improve health. I know her work in that area mostly as her being the founding director of the Siren Network, which is a national network funded by Robert Wood Johnson Foundation. I believe, right? RWJ is still your primary funder?
Kaiser, RWJ, a few other amazing investors, I guess.
There you go. So that is the Social Interventions Research and Evaluation Network. And I won't read the rest of her bio, but it is online, and there are many, many, many good things that I could continue to say, but I think we want to hear your talk.
Thank you so much, Joanne. It's so nice to be here. Yeah, I'm so grateful to the IHPS crew for inviting me to give a talk, to you guys for showing up in person, to all the people who are online. I really am so happy to be here. I confess I'm a little bit more nervous to do this presentation in our own backyard than I am to do some of the national presentations that I do. And I think it's because I actually really care what my, our UCSF colleagues know about our research and that you guys are excited about it and invested in it, but it is somewhat more nerve-wracking. So yeah, I'll just confess that before I start. But thank you for being here. And I hope I don't embarrass my team, many of whom are here in the room today, and without whom this work really would not be possible. So I am going to give a presentation about what the healthcare sector can do and is doing about patients' social conditions. I will, let's see if I can advance the slides. Look at that. Good start. I will kick off just by not only confessing something, but acknowledging out loud what probably everyone has already seen firsthand. Social determinants are in vogue in the U.S. healthcare sector. So questions about our social care roles and responsibilities have become a central focus not only of healthcare-based reports and papers and conferences, but also of so many clinical innovations and payment models, both in the public and in the private space. There's just so much happening that sometimes it feels like you could be crushed by the massive social determinants of health snowball that is coming down a very steep hill. That snowball is the focus of my research and policy work and why Joanne and Beth invited me to come and chat with the IHPS community today. But if you were to believe all of those webinars, reports, etc., that we get every week on social determinants, assessing and addressing social needs in the context of healthcare delivery, you might think about that topic. You might think that it was going to fix everything that ails the U.S. healthcare sector. And sadly, I am here to say that that is not probably true. We're here in the Bay Area, so I'm assuming the technology startup language is familiar to most of you. I think I can pretty fairly say that we are at the beginning of what our tech friends would call a technology or an innovation hype cycle, where these early success stories produce, kind of catapult us to this peak of inflated expectations. And I like to think that our job as researchers is to make the subsequent trough of disillusionment a little bit less deep and the slope of enlightenment a little steeper so that we reach the plateau of productivity a little bit faster by finding the innovations that have staying power. So, in that context of lots of enthusiasm around social determinants of health in the healthcare sector, along came COVID, which accelerated both interest and innovation in this area by underscoring the very powerful and often devastating intersections of health and social adversity. So in the acute pandemic setting, all of a sudden, we saw tremendous change in the acceptability of addressing social needs in the context of care. And if the tragedy of COVID alone weren't enough to accelerate healthcare social care practices, it also really magnified, as all of you know, healthcare inequities by race and ethnicity in a way so intimately tied to social determinants of health. So social determinants really quickly became a key component of strategies to address racial health equity across the sector. All that to say, there has just never been a greater interest in or need for rapidly figuring out how social care might improve health and health equity. So my plan is to use our time as a large group to share a framework we developed as part of a 2019 National Academy of Medicine committee that was so uncomfortably titled, Integrating Social Care into the Delivery of Healthcare, Moving Upstream to Improve the Nation's Health. So the National Academy is good at a lot of things, but they're not good at titling things, or at least not pithy titles. I do like to use the report to anchor my presentations because it provides a very useful organizing framework to categorize the different types of healthcare activities around social care that have really blossomed in the last decade or so. So as we march through the framework, I'll share some of the latest science relevant to each category of the framework. But essentially, the goal of the committee was to explore the roles and responsibilities of the healthcare sector in addressing, both identifying and addressing social conditions as a strategy for improving health. So I do want to just take a second to talk about definitions, because as we explored this topic, the committee did their very best to be consistent about the language that was being used in the report, because there's just so much overlap in the language that is being used to characterize work around social determinants. So for instance, we described how social determinants are not a synonym for population health. They're just one part of what influences both individual and population health. We talked about how social determinants are neither good nor bad. They're like the air we breathe. They can be health promoting and they can be not health promoting. And then finally, we talked about how social determinants is really an umbrella term that can refer to very upstream social, political contexts, policies, programs, institutional practices, and they can refer to very downstream social risk assets and needs, the kind of downstream material manifestations of those upstream factors. The downstream manifestation, social risk assets and needs, is really where we've seen the healthcare sector lean in the most. So the focus of this presentation is really much more on those downstream social risk assets and needs. So let's talk about the framework. The core of the committee's report was this framework, 5 different ways the healthcare sector is already providing and could strengthen social care to improve health. The first 3 categories, much more focused on clinical delivery systems. The last 2 categories, more focused on community and community investments to improve community level health or population health. I'm going to spend the majority of the time talking about the clinical delivery system innovations and science, but I'm happy to talk more about the alignment and advocacy categories at the end or in the discussion section. So we refer to the first of these buckets of activities, and each one of these buckets really consists of many, many different kinds of initiatives, but they're good kind of places to hold, to hang your hat. Each of the buckets is. We refer to the first one of these as awareness activities, or strategies that healthcare systems are using to collect information about patients' social conditions. It would be surprising to me if many of you in the room haven't heard about these, because even on the clinical side, UCSF Health just sent out an email yesterday about how they are launching their own social risk screening and documentation program. It's happening. It's coming soon to a theater near you. Kaiser recently sent me a notice as a Kaiser member saying, hey, we want to know all about your social needs. But it's happening in many, many different healthcare systems. We'll talk about why. But the category of awareness actually includes a very diverse set of initiatives where patients are just being asked about their social needs in the context of a care delivery setting, or in health risk assessments that are being conducted by insurers. Everybody is getting into this game. There are also systems that are buying big consumer data about your bankruptcy history, your purchasing history, your incarceration history. Other people are mapping area level socioeconomic data and crossing those data with patient addresses. So they're using your zip code data to kind of guesstimate your social risks based on your neighborhood's social deprivation index or some other index that indicates your socioeconomic status. At the individual patient level, much of the research that's happening around social risk awareness, though, has revolved around these new social risk screening tools that have been endorsed by groups like the National Academy, the American Academy of Pediatrics, the American Academy of Family Physicians, the National Association of Community Health Centers. I could go on, but as many of you know, there's actually been a vexing lack of consistency in the tools that have emerged in this space. So I've just thrown 3 of them up on this slide, but you can see they don't all cover the same domains of social risk or assets. And they, even when they include the same social risk, they're not using the same measures to assess those social risks. They also differ a lot in length. So on our website, you could find a list of many of the other multi-domain tools that have emerged in this space. Our colleagues in Seattle and Portland have done some interesting work just demonstrating that none of the common social risk screening tools being used has actually followed the ideal steps of gold standard measure development. So some of the individual items might have been quote unquote validated, but none of the comprehensive tools has actually gone through these kind of standard steps. And many people, in light of there not being a gold standard, actually report even modifying the existing tools. So what we do know is that using, sorry, just one more comment about the last slide, is that using different tools could lead to really different rates of responses. Even like it's just unclear what the prevalence might be if you use one tool in one setting and another tool in another one. So, okay, there are tools out there. People are increasingly using them. But what do we know about how patients and patient caregivers feel about social risk screening? So our Siren colleague, Amelia DeMarcus, led a study a few years ago that involved a 1,000-person survey in 10 different clinical sites around the country, including 4 pediatric settings, some ED settings, some primary care settings, serving both adults and children. So we asked patients in the course of that survey about whether they considered it appropriate to be asked about social risks in healthcare settings, and moreover, how comfortable they were with the data on social risk being incorporated into their electronic health record. So you can see from these pie charts that the majority of patients reported being either very or somewhat comfortable with both. The survey showed no differences in patient acceptability across the 2 different screening tools that were used, and acceptability was not significantly associated with race, age, or gender. So given that the tools exist, they're more or less acceptable to patients, and we're, slowly learning how to ask questions in ways that might lead to meaningful interventions. We'll talk about interventions in a few minutes. You might then wonder about the extent to which social risk screening is actually already happening. So it feels like it's happening a lot. If we just judge by my experiences at UCSF and Kaiser, but people have tried to actually measure that at a national level. So this is some work from our amazing UCSF colleague, Teresa Fraze, affiliated with IHPS, who analyzed findings from a national survey of healthcare organizations, including hospitals and outpatient practices. And people who are responding indicated that a majority of them were already routinely screening for at least one of the big 5 social risks. So that is housing, food, transportation, IPV, and utilities security. And about 20 to 25% indicated that they were screening for all 5 of those. So 90-ish% said screening for at least one, about 25% said they were screening for all 5. But keep in mind that those surveys, and actually Teresa's survey, and then it wasn't her survey, but the work that she did on the NHSOS, National Health, NHCSOS, I can't remember what the initials are. All of the work that's been done on prevalence, or most of the work that's been done on prevalence, hasn't included a denominator. So you could imagine if you're a busy healthcare executive and you're being sent some survey about what's happening in your healthcare system, and you know that there's some social risk screening maybe happening for patients enrolled in a care management program, you answer yes, but maybe that's just a small fraction of the population that you're serving. So we really just don't know how prevalent this is. There have been a couple studies done with patients in select care settings. So for instance, community health centers, where my dear colleague Yuri Cartier found that, who's sitting at my side for those of you online, found that many fewer patients actually report being screened within the last 12 months for even one social risk factor. So Yuri looked across 23 different surveys and found that the rates of screening really depends on who you ask. We are starting to understand some facilitators for patient-based social risk screening. So technology seems to be one of them. As many of you might have seen, major electronic health record vendors like Epic and Cerner and GE Centricity and many individual health systems have actually created their own modules to incorporate social determinants of health documentation capacity in the EHR. But technology innovation is unlikely to be sufficient. So this is a slide from a study that Ocean, a big EHR platform that provides technology or EHR services to over 600 community health centers in the United States that we do a lot of research with. They actually turned on EHR-based social risk documentation tools a number of years ago, and in their first study on uptake, they found that even though some clinics did a lot of documentation using the new tools, many clinics didn't, and the variation was so tremendous. So they saw 17,000 screenings over the course of their couple years of studies, couple-year study, but the vast majority of those took place in only 4 community health centers. So it isn't going to be enough to just turn on tools. So payment incentives are increasingly being used to increase screening adoption. This is a slide from a private payer that incorporated social risk screening as a reimbursable quality measure. This is actually from Kansas. We're certainly seeing that happen more and more amongst both public and commercial payers. So could financial incentives work? Maybe. So this is a slide just summarizing a big R18 that our team is involved in from AHRQ, where we're trying to look at, okay, well, what are the different implementation strategies that could make a difference for screening? So we have this amazing natural experiment underway in Oregon that is the subject of the study, where some community health centers are receiving a financial incentive and some community health centers are receiving rich technology supports accompanied with an in-person trainer, or actually a online trainer who occasionally shows up in person. And some clinics are getting both. Some clinics are getting nothing, but some clinics are getting both. And so we had this opportunity to look at, okay, well, what's the added benefit of the financial incentives? And this has not yet been published, but because I like you guys, I'm going to give you the sneak peek of our early results. You can file them away in the category of things that make you go, huh? Because we actually found, oh my God, my animation actually worked. It's so exciting. So our preliminary data suggests that there's no added benefit of the financial incentives for social risk screening in community health centers. So it's unclear what these findings might mean for a whole spate of new state and federal quality measures, which will include payment, now emerging that are designed to increase social risk screening activities in different healthcare settings. And I just want to give you a flavor of how big a deal this is.
Can you just tell us how big was the incentive, or what was the incentive
Oh,
structure?
yeah. It changed over the course of time. So it started at $10 per screening, and it then eventually went down to $2 per screening, but it was $10 for the first year. Holly Wing, also in the room, is helping to lead that study. And Holly, do I have that right?
Yep, that's right.
Okay. Phew. We have quality checks during the presentation. Oop, let's not let's not go past that slide so fast. So this, I just want to give you a couple of examples of the federal level quality measures. So this year, the National Committee for Quality Assurance launched new measures related to screening in their health plan accreditation program, HEDIS. I'm sure that's familiar to people in the IHPS audience. Yesterday, I actually spoke with a group of psychologists who don't deal at all with quality measure work, and you're like, what are you talking about? And I realized, oh, I have to go look that up. The new measures will shift from voluntary to mandatory reporting next January. So they're not yet linked with payment, but they are about to be. So we're seeing lots of health systems scramble to figure out how to put the screening into place. CMS also just launched voluntary reporting for social screening that they're expecting to link to payments in future years. So curiously, the social domains and some of the details of these measures differ across programs, which I'm sure is driving health systems absolutely batty. The upshot, though, is that we're not sure if they're going to work because there may be things about social care that are very different from the other things that we use quality measures for. It depends a lot on people's confidence. It appears to depend a lot on people's confidence that it won't make patients uncomfortable, that there will be something that they could do about the social need that is identified in ways that are different from other clinical activities. If I have piqued your interest in the science on social screening in healthcare settings, I will triple underscore exclamation point that we have a massive report that is nicely organized into a bunch of different chapters based on you could look it up based on your specific interest in screening, that is called State of Science on Social Screening in Healthcare Settings. It's free, and it summarizes a lot of the evidence that's been coming out in the field, only as of summer 2022. It's hard to keep this up to date because there is so much literature coming out on this topic every single day. Mm-hmm. But let's move on, because the next 4 categories in the National Academies Framework explore what we should be doing with the information that we are increasingly collecting, and I think is much more interesting. So how are we supposed to use it? What are the interventions that should result or that we should use to respond to social risk? As I mentioned earlier, the first, 2 of these categories, so adjustment and assistance of the intervention categories, are much more focused on clinical delivery systems, and the latter 2 are more focused on community-targeted strategies. So let's start with the clinical ones. The first of the healthcare delivery-focused strategies refers to situations in which social risk data are just being used to inform clinical care decision-making. So these kinds of adjustment strategies might be right at the point of care or at the payment level. So for instance, we might select a less expensive medication for a patient who can't afford their copay, or we could use social risk information to adjust payments going to healthcare systems. So you have heard about this in the form of social risk adjustment. It's a hot topic in health policy journals. And policy conversations. We're not going to have time to go into that a lot today. I'm happy to talk about it in the conversation at the end. But just know that's a way in which we are adjusting clinical care decisions, not clinical care, but healthcare decision making, specifically around payment, based on information about patient or population level social risk. So I do like to think that on the clinical side, the adjustment work is stuff that we do as providers, especially in the safety net, every single day. So we just don't do it that well or systematically. We accommodate social factors that could interfere with medical treatment. We try to improve access to patients who don't have great access. We have weekend clinics, we have evening clinics, we provide interpreters, we have mobile vans. We provide low literacy materials for patients who need them. We also use social data to inform diagnostics. So as an example, the mini mental status is adjusted in theory for literacy level. Have I ever seen anybody adjust the mini mental status based on literacy level? Never. Our electronic health record systems, when we put in the information about mini mental status scoring, do they give me a pop-up saying, hey, did you adjust that for literacy level? Never. We also, I mean, if you read the guidelines for care for healthcare for the from healthcare for the homeless for persons who are experiencing homelessness, we should be adjusting our recommendations about HIV screening and hepatitis B, C screening and hepatitis A vaccinations and you name it, based on patients' homeless or housing status. We also use social risk information to adjust our treatment plans. So we just once daily meds to accommodate work schedules. We reduce med costs by selecting generics, et cetera. But a major obstacle to adjustment, or what I sometimes refer to as social risk informed care, is that we just don't think about that for every patient every day. And as I was kind of alluding to, our electronic health systems are not designed to help us in any way do that in a systematic way. In part because we still need better evidence about how to systematically apply social risk data to improve conventional care. And then we need to have the right social risk data available to us at the right point and for the right provider. So the big research questions in the adjustment category include questions like, okay, if I increase awareness about patient social risk, could that lead to an intervention? And then certainly do those interventions actually lead to improvements in patient health and well-being? There is some exciting research that's happening in this space generally. I would say that a lot of people have been doing this for a long time, but I love the work that is coming out from people like Tiffany Vano at University of Michigan, Danielle Hessler, one of our co-directors at Siren, and Rachel Gold at KP, where this is actually an example of Tiffany Vano's work, where they actually just talked with providers who are caring for patients living with diabetes, and they said, well, are you already doing this? And everybody said, yes, we are doing this. We are already changing the target level blood sugar control. We are already changing the medications that we select based on information about patients' social needs. I love it because I think it's a useful model for thinking about, okay, well, what are other people doing? What are people doing in X condition? What are people doing in Y condition? It's just a nice way to think about, well, what are the different kinds of categories of adjustment? Like with awareness, we are certainly seeing ways that technology might be one way to increase the adoption of adjustment activities. So, for example, we could nudge prescribers to help them make prescribing decisions that are more responsive to cost. Well, maybe we can. So this is an example of a technology tool called a real-time pharmacy benefits tool that as of 2021, CMS mandated that every health system that was serving patients who have Medicare Part D coverage, that everybody have one. We have one. We actually have a couple, I think, in the UCSF system. Very few people use it. We haven't seen incredible effectiveness data from it. But you could see that this kind of tool that tells you the differences in different comparable medications, or at least in theory, comparable medication, the different costs to the patient could be really helpful, right? So if you're at the point of care and you're trying to make a decision between X diabetes drug and Y diabetes drug, or in this example, different oh my God.
Anticoagulants?
Thank you, anticoagulants. Thank you. It would make a huge difference. I mean, I would pick warfarin in this case if a patient if the patient couldn't afford the other medications. It could be a medical adjustment strategy for patients who were struggling with cost. So one of the biggest studies to come out on the real-time pharmacy benefits tool is this large cluster randomized clinical trial in New York that included almost 200 practices, where they found that the real-time pharmacy benefits recommendations actually did lead to overall to an 11% reduction in patient out-of-pocket medication costs. And among the high-cost drug classes, because some medications cost a lot more than others, they found a 40% reduction, which was incredible, right? So if we actually use them, that would be an incredible change for patients' experiences. But there's a little bit of a wah-wah moment here too. The lower cost recommendations were made for only 4% of medications. So the tools are not yet up to par. They're not quick enough. They don't have enough insurance information. They're not where we want them to be, but they're getting better all the time. there are high hopes for them, and certainly the federal mandates are going to probably lead them to be more impactful with time. The federal government, not beyond the real-time pharmacy benefits suggestion, or not even mandates, I should say, is also hoping that other forms of technology are going to really help clinicians make better decisions at the point of care to serve patients who are facing socioeconomic barriers. They're not just thinking about real-time pharmacy benefits tools. They are thinking about other things like clinical decision supports, which I mentioned earlier. Just last month, literally, they came out with this report about, oh, maybe we should be thinking about social determinants of health and incorporating information about social risk in our clinical decision support tools. That was kind of music to my ears, because for the last 5 years, we have been involved in a trial trying to create those clinical decision supports, where at the point of care, a clinician who is making a decision would use information collected about a social risk to actually facilitate adjustment and documentation. And I just want to give you a cool example of how that might work. So this is actually one of the tools that we've created, and it's based on Hilary Seligman, also an IHBS affiliate. Great work that Hilary Seligman and her colleagues have done, showing, they had this really interesting study showing that patients with food insecurity who are on SNAP benefits and insulin are more likely to be hospitalized at the end of the month when their food benefits run out. So our tool says to providers who are starting an insulin prescription or changing an insulin prescription, hey, remember this cool study where we showed that patients on insulin who are food insecure are more likely to be hospitalized, and have a conversation with your patient because they have expressed that they have food insecurity. Have a conversation with your patient about changing their insulin dose. Okay, so that's an example of what this could look like. I will say it feels a little uncomfortable because I don't want to change somebody's insulin dose. I want to make sure they have enough food all the way through the month. So that brings me to the next category of activities that we talked about in the National Academies Committee, which is assistance.
Yes. So before we leave the adjustment, I mean, I'm struck by your last on the list around same day appointments. And certainly I think it's done. But one of the things we see here in California in our federally qualified health centers is their Medi-Cal program prohibits same day billing, they call it, for medical care and behavioral health care. So if you have someone who needs both of those, the Federal Health Center cannot get paid for both visits on the same day. So that creates a real disincentive to do the thing that would be more convenient and understanding of the patient's potential transportation needs.
I can't tell you how many conversations I've had about that. It is absolutely crazy.
Right.
I see Joanne right next to you, like hitting her head for those of you
Yeah,
online.
but that's my point, is that for everything that's maybe a good financial incentive to do the right thing, there are some policies that
Make it so hard.
make it very hard.
100%. Yeah, spot on example. So yes, we were talking about both individual level clinical encounter change and systems change that makes it possible. Let's talk about assistance for a few minutes. We have heard more, I think, about assistance in the news and in media and in conversations in clinical settings. These are examples where we are using healthcare dollars to, in some way, intervene on a health, a social factor that is negatively affecting health. And in some ways, this feels better. I think that's why we've heard more about it. This feels more ethical. If we find out that the patient doesn't have enough food, we want to act on that. But historically, it's been very hard to use healthcare dollars to pay for social services. That is changing, and I want to spend some time talking about that in the next few slides. But just to make sure everybody's on the same page, these are examples. Well, certainly the food is an example. One of the examples I use in adjustment is sometimes like, okay, well, let's use non-refrigerated food prescriptions for people who don't have refrigerators. but it would feel a lot better if I got them a refrigerator, right? So those are the kinds of examples. People are doing this. So every hospitalized patient at ProMedica in Ohio and Michigan is being connected with food programs routinely. Roots Community Health Center here in our own backyard in Oakland is helping their patients obtain living wage jobs when they find out that patients don't have a steady source of employment or other income. And now under our CalAIM waiver, which we will talk about, we are paying for housing support specialists. And in some cases, at least the first month of housing rent. It's amazing. This is a sea change in healthcare policy that is allowing us to pay for social services. But again, like in the adjustment example, these are interventions that are sometimes part of care, but not routinely or systematically built into practice. So like in the case of adjustment, there's some big questions about whether social risk screening leads to more assistance type practices, and then whether those interventions will lead to improved health and well-being. A big problem with trying to summarize the literature, though, on assistance is, holy cow, what is in this box? Oh my God. That's my Jack in the Box. That's an old school Jack in the Box. Or no, it's a fast food mediated Jack in the Box. So there are just so many different things in this box, ranging from very low intensity interventions, like I just handed my patient a list of information about the social needs. There are some tech-enabled versions of that, but there are also very intensive versions of that, where you're providing one-on-one assistance for 6 months or a year or whatever. I mean, there are just so many different things in this box. I'm going to give you a few examples and just note that they are so all over the map. So this is an example of a trial that actually showed a positive health impact that came from our colleague who is in North Carolina, Seth Berkowitz, and his team, although at the time I think he was in Boston. So they showed that a pretty low intensity intervention that involved a volunteer navigator, student navigator, actually led to changes in in LDL lipids and in systolic blood pressure, which was amazing. The ones that I'm mentioning here are the examples of the already small number of studies that have had some kind of synthetic or created either an actual or synthetic control group that have shown some kind of positive impact. The vast majority of studies in this area have not included any kind of control. So this is another study by the same team that showed that medically tailored food boxes led to reductions in readmissions and healthcare costs for Medicare and Medicaid beneficiaries. This is some work coming from Shreya Kangovi's team on a massive community health worker program that they have at University of Pennsylvania, showing that for every dollar invested in their community health worker program, they had a positive return of about $2.50. And she's done a whole series of RCTs that are really high quality. So some of you tracking any of the literature in this space may have heard about a very highly publicized RCT published in 2020 that involved a collaboration with J-PAL North America and the Camden Coalition in New Jersey. So this is where I shift from, oh, there's some cool positive findings to, maybe it's not all sun and roses. I can't remember the expression, but like it doesn't always show, we don't always see positive effects. So in this particular study, patients were recruited during a hospitalization and they were randomized into one of two arms. In the intervention arm, each patient had this designated care team consisting of a nurse and a community health worker. They got all sorts of supports. And the team worked longitudinally with patients after discharge. It was a big study, about almost 1,500 people were randomized into one of the two arms. And people were so excited about this. And then this massive paper came out in the New England Journal of Medicine in 2020, I think, 2020, that Caroline's nodding at me. She's my other quality check, that showed that there was really no difference. So the people who got this major one-on-one intervention had the same number of readmissions as the people who did not get that. People have looked at that study and had all sorts of explanations from it. So to explain it, the patients were generally younger than we've seen in some of the other successful studies around care management. They were sicker. They were very, medically and socially complex. The outcomes only looked at readmissions. They only looked at a year. There also were questions about the availability of community services to meet the needs of the population that was being served. And then, because this was such a hot thing in Camden at the time and had been written up in the New Yorker and in the whatever, every publication had talked about this amazing new model that Jeff Brenner had created in Camden, New Jersey. Maybe the control group was also contaminated. There are lots of things that could have happened in Camden, but one of the things that I think we've come away with is that focusing on the highest risk population may not be where the money is at. And that it will be important moving forward to talk about, well, what are the appropriate interventions for different people on our sort of classic tiering system of like the people who are the highest risk, the rising risk, low risk, no risk pyramid. Jenna.
Yeah, so I too have for a couple years, well, more than a couple years now, been the evaluator of a set of community paramedicine pilot projects across the state, including one here in San Francisco, where they work with they work with high utilizers, super, mega, whatever you want to call them, utilizers. And, I think the descriptive data from those projects would say that you do see impact there. We've tended to look more ED visits than admissions. You see some impact, but then you see regression to the mean. And why is that? Well, at least here in San Francisco and San Diego, the two places we've looked at this the most, these are folks who often are homeless, which is an independent risk factor for not doing well, have mental illness, often have substance use, often have both. And so I think, and one of the things, in our quality of work and is heard loud and clear is the challenges of navigating two things. One, getting other agencies to play well with you. We do that fairly well in San Francisco. They don't in San Diego. But also, even when the agencies are all on board, where are the resources? Can you get a detox bed when the person is ready? Can you find supportive housing at the level that person needs? And so I guess I wouldn't say we don't work with super utilizers, but I think a lot of the social interventions that we're doing, my view is that the folks they might be most effective for are not the super utilizers.
Yeah, I 100% agree. I think, one of the, it depends on what outcome you're looking at, right? So if you're looking at costs, maybe you need to be looking at the rising risk. I also feel like you brought up a point that leads directly into the next slide, which is just that, just to underscore that this problem of a bridge to nowhere, of asking patients about their social needs and then not having a place to send them, is not ideal and really problematic. So, if you take away nothing from this presentation, you should take away that assistance programs are unlikely to make any difference in health or healthcare utilization if as a country we don't in parallel invest in our social services safety net. So that's I think that that's a given, but there's a lot of investment happening in healthcare right now, and we haven't seen the same kind of parallel investment in the social services that actually will make a difference in people's social conditions. I hope we come back to that point, Janet, if I can wrap this up. So if you are interested in more evidence on assistance, there certainly our website, we have a easy to search evidence and resource library that Holly has really been such a massive, has been massively responsible for. So anything good that happens there is because of her, and anything bad is because of me. And then PCORI actually now has an evidence map of some of the highest quality studies in this field that is also relatively easy to search. I do want to just make the parallel to awareness and adjustment that technology is increasingly being thought of as something that could facilitate assistance strategies. We've seen a multi-billion-dollar investment in these new technology startup companies like Unitas, and UCSF actually, or UCOF actually just purchased or created a contract with Find Help. These platforms that are trying to collect information that we used to keep in like little pockets in our white coats about social services in our patients' neighborhoods or in the communities that we were serving. They're now putting them all into one electronic health record or one electronic platform and trying to make it easier when you identify a social need to connect people to the right resource. Caroline and Yuri, sitting on my left, have actually done some remarkably cool work showing that Well, it turns out we might have these resources, but getting people to use them and then actually the availability of those resources may not make that big of a difference because a lot of people who you're referring to services already know about those services and either they're not sufficient enough or or there are other reasons, there are other big barriers to people using them. Okay. Payment also anticipated to facilitate assistance, of course. And this I actually feel like is a little bit of a positive. Those policies are coming fast and furious in state and federal guidelines, policies, standards, rules, regulations, not the least of which are the quality measures. So alongside the quality measures for screening, we've seen some quality measures that are related to assistance. So I'll give you another example from the Joint Commission. So the Joint Commission, which accredits and certifies hospitals and other healthcare organizations, just this year included a new standard for hospitals to not only screen, but then to provide information to patients about community resources and support services. Again, hospitals are now scrambling to figure out how to put those requirements into place. But even more exciting than that, to me, are this new spate of Medicaid and CHIP policies and payment levers that people are using to pay for social services, which is super duper cool. So you don't have to read all of this slide. What is important is that this is CalAIM. So we have an example right here in our own backyard that is absolutely massive. Where our Medicaid waivers, both the 1915B Medicaid managed care waiver and the 1115 that lets us do kind of fun and innovative things, are leveraging the in lieu of services flexibilities that the federal government has said that we can do, and said you can pay for social services. And what's even cooler is that in January, just this year, Governor Newsom made an announcement associated with the state budget saying, well, not only are we going to pay for some social services, we're going to push CMS even further, and we're going to ask for paying for, this is the example, 6 months of housing, of rent support for select populations. Never before has that ever been done using federal healthcare dollars. So it would be amazing if that were to happen. CalAIM is pushing the limit. There are a few other states that are doing these innovative things, but a lot of people are looking at California to say, oh, well, if they can do it, I can do it too. It's not just Medicaid, though. This is happening in Medicare, too. So I put this up as non-Medicaid because it's not only Medicare. It's actually a slew of other things and other places where we're seeing these policy and payment levers being used. But the cool one that I think from the Medicare Advantage program is just how much flexibility we're seeing in the supplemental services that we're allowed to use now for Medicare Advantage beneficiaries. So people like you or healthcare insurers like Humana and Unitas and you name it are now experimenting with different forms of supplemental benefits that are related to providing non-health services. It's cool.
Can you give an example?
Yeah, so food boxes is probably the most common one, but there are other transitional supports, weatherization, non-medical transportation. So instead of just going to the doctor's, using a Lyft ride to go to the doctor, you could maybe go to the grocery store, but people are experimenting with lots of different things. Okay, upshot. There are a lot of early clinical system adopters out there who are doing social care. There's a lot. And there are a lot of policymakers who are racing to keep up with them. And then there are a lot of researchers way behind who are trying to say, wait, shouldn't you be informed by research? But the ship has left the port. There are just so many gaps in the high quality research in this area, and we are racing to keep up. I don't want to close this talk without talking at least briefly about the ethics and equity questions that I think are coming up in this field. I've just thrown a few of them up on this slide related to the 3 categories that we've just talked about, but there are so many. So screening for food security at every visit. Could screening actually exacerbate perceived or actual discrimination in the healthcare system? So we have plenty of examples to show that the healthcare system is built on a racist foundation, continues to perpetuate racism in so many different ways. And is the experience of screening going to make that worse for patients who've already been so mistreated by the healthcare system? Could linking patients to community-based organizations, when we have, when we try to make a link and there is no service there, could that actually make people's experiences of healthcare or their trust in the healthcare system worse too? Yeah, it probably could. And then in the example of adjustment, I have so many questions about, okay, well, is it okay to change people's medications, to choose different medications based on the affordability? Like, ah, is that just rationalizing poor care for poor people? Which, holy cow, that doesn't seem good either. We already have a two-tier healthcare system or more. Is this just making that worse? So we have a lot of things we got to grapple with. So that's the content that I wanted to share about the strategies that are most directly relevant to clinical delivery systems, both at the system level and then also at the encounter level or clinicians. But I will just mention that the committee's charge, as I referred to earlier, included exploring other approaches to the healthcare sector is taking to strengthen the social resources landscape. Including by increasing alignment, investment, advocacy at the community level. So it was here that the committee really underscored how important community level efforts are to social conditions, and that the healthcare sector could be a really strong ally in that work or advocates for that work. And Caroline and Yuri and one of our former Harkness fellows, I see we have a Harkness fellow among us today, but one of our former Harkness fellows, Matilda Allen, did a really beautiful paper on some of the alignment strategies, trying to similarly create a framework for understanding the many different ways in which healthcare systems could be leveraging what they do to increase community investment and advocate for social conditions at the community level. So if folks are interested in that, I threw the reference up there. And I apologize for not giving that those two categories justice, but we only had an hour, and I want to leave the last few minutes for conversation. So of course, the National Academy Committee recommendations were to just redesign the whole healthcare system, which, okay, that's a lot. They did have a little bit more concrete, they did get a little more concrete. That's going to require a workforce and a digital infrastructure and a change in financing. And if you read the report, you will see there, it gets more detailed from there. There are a lot of recommendations, some of which are actually already underway, which is cool. And it is just so fun to be in a field that is changing so rapidly. You blink and then something new has come out of the gates. So if you have any questions about the research, please use our website. Our job is to catalyze more high quality research in this area, to collect and disseminate research, and then certainly to do consulting for anybody who is interested in this work. So should we spend a few minutes just chatting about any of that? That's what I got.
Do we have
You
questions
have
from the
questions
people
on Zoom
online?
to start with?
There's one, but it's pretty long. Can you see the question mark?
I can't, but maybe if I ended the show, I don't know. It's just
Maybe you
dark.
can, maybe y'all can read it.
Sure.
Sorry.
Okay. Thank you for your excellent work and great presentation. Our NIMHDC funded multiple chronic disease disparities research coordinating center at UCSF is using SDOH based on the Davis and Shanley framework, environmental factors, arom, hydrom, pterom. I'm not gonna read all of them. Do you have any thoughts about this framework and which includes some additional domains, etc.?
Oh wow. Arom, hydrom, pterom, nutriome, biome, phylum, allelome, legome, econom. I have thoughts, which are, I don't know any of those words. I don't know enough about that framework. I will say that one of the interesting, I love this question because I think it underscores how difficult it is to move from where social determinants work has been to a clinical setting. So a lot of the research on how social risk is experienced was done outside of clinical practices. And we were looking at things like level of air pollution and noise and neighborhood level factors. And there's so many different things, right, that fall under the bucket of social determinants, environmental determinants, etc. And figuring out how to go from the ideal questionnaire that is going to cover all those different topics to a set of feasible questions in a clinical setting has been really, really challenging, and why we see so much, variability in the questions that are being used in different settings. So that framework looks like it includes a lot, like, fancy terms for some of the like very specific downstream manifestations of adverse social conditions. And I feel like, oh yeah, I mean, it looks very comprehensive. How do we keep the comprehensiveness and make it feasible to use in a practical setting? That's probably not exactly the question that you are interested in. I'd be happy, whoever asked that question, I'd be happy to chat about it more. But that's what I'm going to answer. Yeah.
Yeah, what I find interesting in this, and like I'll just pick on the pharmacy, right? The pharmacy guidance
Yeah.
systems is to some degree the lack of evidence, both sometimes about efficacy of different things. It's like, oh, well, the standard of care is to do blah, blah, blah. And it's like, okay, but is that really the best care? Which Kevin Knopf has talked about for cancer care, that there's a lot of things done for cancer care where it's like, really, your standard of practice is to do a scan 3 times a year, but do you actually have evidence that gives you a better outcome than twice a year?
Yeah.
So am I rationing or am I using evidence-based care? So you've got that.
Mhm.
But on the
Great
pharmacy one, also thinking about, warfarin looks like it's super cheap, so we should do it. Except that if you're on Coumadin, you got to get your blood taken how many times a week?
Mhm.
And that probably has a copayment cost for the individual, not to mention the time to deal with it.
Yeah.
And so, so there's, and it's like, oh yes, in your 10-minute appointment or 15-minute appointment that you get as a primary care provider, I dare you to navigate
That shared decision making.
have fun with that.
Yeah.
But that is the bridge to nowhere piece of it. It's like, great, you asked about social determinants of health. Now deal with it in 10 minutes or less.
Yeah. Oh, I love that, Joanne, because it's like another bridge to nowhere problem, right?
Right.
It's like not on the assistance side, but on the adjustment side. And I feel like there's been tons of resistance on the provider side to do this more systematically for those reasons. Because what we say, we're not trying to create best practice alerts or decision supports that tell you to do something. We're mostly creating alerts that say, this is something where shared decision making would really matter. And finding time to do that is not easy. It's such a good point. Thank you for raising
The
it.
whole reimbursement system is a problem.
Rita, did you have a question?
Yeah, I know you didn't get to the advocacy piece, but I'm curious about what that looks like for healthcare systems to do. I think I shared with you a commentary I did with Sandro Galea where we wrote about something very similar, like what should healthcare systems be doing to address social needs? And our final thing was lean into advocacy, like healthcare systems should be getting money out of healthcare and into the social safety net, which is underinvested in, as you touched on. And I was just wondering, is their movement on that? Or like, I feel like it's against healthcare systems' interests, maybe, if all they're thinking about is their financial interests, to get money out of them and into the social system. But is that happening?
Well, Carolyn, you should feel free to weigh in here too. I'll give my 2 cents, and then I feel like we have another local expert in the room. So it is happening. And I think it's happening. I mean, I'm going to give the example of Kaiser, where they have said that social health is on par with physical health and mental health in their system. And they are making tremendous investments in housing in the communities that they serve. They're advocating for changes in food benefits. They're doing things that they think are advocating for policies that they think are aligned with their social, physical, mental health pillars. So I actually do think we're seeing it. We're also seeing it be in some ways required from the state or from the feds. So an example is Arizona, where their state Medicaid policy requires that all their Medicaid plans invest 6% of their profits every year in community-based nonprofits. So while not advocacy per se, it is a form of required alignment or investment. Carolyn, you probably have a zillion more examples.
Yeah, I mean, I think I would just add to, hi, I'm Caroline Fichtenberg, for those that I don't know. Yes, it is happening. I wouldn't say it's happening a ton, but I think one of the places that it's happening also is in this world of anchor, the anchor institution movement, which is this idea of healthcare organizations using their business operations, their investment dollars, and their voice to help improve social conditions. And there's actually a policy day that they organize every year. We have a bunch of healthcare organizations that go to speak to members on the Hill. And we've done a few interviews to try to understand the impact of that. And actually, advocates on the other social side, like on housing, et cetera, are really excited about it because it really is different when you have the head of the hospital come to speak to somebody on housing. And they're like, wait, you're a hospital, why are you talking to me? And so the impact is potentially can be meaningful. Of course, advocacy is not easy and it's going to take a while and probably a lot more, but I would say we're seeing it. And I think the incentives are potentially getting more and more aligned, right? Like the more hospitals are being, have incentives to be improving the health of the community more globally, the more they're going to see the benefit of doing this.
You guys, we've reached the end of our time together today. This does not have to be the last time that you see me. Really would be happy to chat about any of these issues that are clearly near and dear to my heart and to our team's heart. Anytime. We have an open door policy, so please come by via email anytime. Thank you so much for having me and for making it so fun.